Alright, we're going to discuss primary secondary assessment. We're going to start off with the primary. These are two different assessments. Your primary assessment is when you're approaching your patient. Your primary assessment has to be quick. If you do it right, you can obtain your quick primary assessment in about a minute to a minute and a half. It all depends on the situation. Primary consists of basically, locating your patient. Depending on what's going on with your patient, if you're trapped in a vehicle or, they're in a house sitting in tripod position, you have to figure out the mechanism of injury or nature of illness. Then you have to decide how many patients you have. Whether you have one or do you have multiple. And if you have multiple, or you have one that is, visually, automatically critical that you can tell, you might want to consider getting extra resources. And you have to determine whether you want to stabilize the patient's spine, which is immobilization, long backboard, C-collar, CLDs. Then you're going to do a fast general impression on the patient. So like I said earlier, they could be sitting in a tripod position. Your general impression, we use acronyms like FEDSO, WARF, and RWB, red, white, and blue. And that's basically breaking down the beginnings of your ABCs, your airway, breathing, and circulation. You gotta pay attention to the chief complaint, but do not get tunnel vision on it. That's a big thing a lot of people do. They get tunnel vision. During your general impression, you need to pay attention to what's around you. Like, if they're in a house, is the house messy? It's covered in filth, mold, animals running around smelling like ammonia, and they have shortness of breath. You have to determine what's going on. And in a scenario like that, it's best to remove them from that area. Get them to some clean air. But anyways, back to topic. After you obtain your general impression and you know your chief complaint, you have to understand level of consciousness. If they're fully alert, GCS of 15, alert and oriented times 4, or if they're unresponsive, you go by AFPU. NAPU stands for, are they alert? Do they respond to verbal, painful stimuli? Or they're just unconscious and unresponsive? You have to determine life threats. You walk in there, the patient, you see tons of blood, and they're still bleeding. That's a life threat. But life threats can also be when you're your scene sizer. If you're approaching a house, the patient's inside, is not responding or anything, you approach the house and you smell natural gas. They could have carbon monoxide poisoning. And that's why they are unresponsive. And you have to have additional resources for that, because it's extremely dangerous, and you don't want to put you or your partner at harm. Then we're going back to the ABCs. When you approach your patient, you pay attention. ABCs is airway, breathing, circulation for a responsive patient. Check the airway, make sure the airway's patent. Make sure there's no obstructions. Then we'll go to B, check on your breathing. Watch those and count those respirations. A lot of people overlook that. Make sure they have proper chest rise and fall. No paradoxical movement. C, circulation. Check your pulses. Take the back of your wrist, put it on the patient's forehead. Get the skin temperature, texture, togger. If you don't feel a radial pulse, go for a carotid pulse. Then after you check your circulation, you need to move to disability. Look at those eyes. Eyes can tell you a lot. See if they're equal and reactive. See if they respond to your neuro assessment, which has a completely different section. After you determine the disability of the patient, you need to expose. Think about your chief complaint. Like, say for an example, chest pain. Expose that chest. Make sure they're not impaled. See if there's any bruising, swelling, any discoloration. Don't be scared to get in there and actually examine your patient. Then this is the point in time where you decide whether, you have to let them go. Or, you have a minute to where you can further assess the patient on scene. But you need to try to keep your on scene time below 15 minutes. Continue with the other assessments. Your secondary assessment is you go further into it. You obtain your vitals. Look at your vitals. Understand what your vitals mean. Because vitals can let you know if a patient's in shock, pain. Then look at your chief complaint and treat it. Do your interventions. We all have protocols. Stick to them. But do not get tunnel vision. If once you get tunnel vision, you're just focused on that one chief complaint, and it can be something totally different. For like an example, chest pain. It's not only cardiac. Respiratory can place pain in your chest, in your back. Mimic a lot of same things. And when you go to treat somebody, like you're given medication, always practice your 5 rights. And always reassess throughout. Look for improvement in the patient. If there's no signs of improvement, look at other things. Try to put 2 and 2 together. It's going to be hard at first when you first start out, but after you do it, it'll fall together, all in place. And after you're treating your patient and you're reassessing, pay attention whether you're having improvement in the patient, if there's any side effects from any one of your interventions. And if there is, there's protocols on how to deal with that also. But whenever it comes to actually assessing the patient and figuring out what everything's going on, and if you get stumped and you come across a dome scratcher, you can always call your medical command and get their outlook on it, and decide where the patient needs to be transported. If they're not in danger, life-threatening, and they want to go to one hospital, by all means, take them. But let them know, like, hey, if this is serious, this is a more appropriate facility, then you need to go to that appropriate facility, and you need to try to convince them.